Now it is. Thank you. Good evening, friends. Today we are discussing diabetes complications. This is my conflict of interest for this diabetes education program, and this is my disclaimer. Now, what is it that we are going to learn in this module? One is, what are diabetes complications? What is microvascular and macrovascular complications? What is diabetic nephropathy, neuropathy, retinopathy, which are the three microvascular complications as such. Now, in this agenda, we are going to look at burden of diabetes, burden of complication, microvascular complication, including the foot. And finally, we are going to summarize what we have learned in this module as such. Now, diabetes burden, as you know, is increasing, not just because of diabetes, but because of the complications as such. Then these complications affect the most productive younger age group in developing countries. Diabetes occurs 1 decade earlier, so also complication will occur 1 decade earlier Indian population, because the younger you are, both quality and quantity of life is affected. Early intensive glucose therapy lowers blood glucose levels and reduces the complication as such. What are the macrovascular complications? Microvascular, as you know, nephropathy, neuropathy, retinopathy, which is due to small vessel involvement. Whereas the macrovascular complication is because of larger vessels, which causes coronary artery disease, cerebral vascular disease, peripheral arterial disease as such. So there are bridges. That means apart from this, what you see is microalbuminuria, erectile dysfunction, cardiac autonomic neuropathy. So the macro and microvascular, in between, these are the bridges you see, the complication of what you see them. Then what are the macrovascular complications? As you know, that even pre-diabetics have the vascular complication as such. It may be 10% of them. Then if you see, even in pre-diabetics, that the amount of complication is as good as newly detected. You have 3 to 5%. That's what you see even in pre-diabetes, meaning that many of the vascular complications start much before the diabetes is recognized or even started also as well. That is how we should treat very early, including pre-diabetes and diabetes, to prevent or postpone the complication as such. This is what we see. Obesity is the probably basis. Obesity is not a disease, but it is the mother of all diseases, because obesity leads to diabetes, hypertension, dyslipidemia, and mood disorders, because depression is more common, heart disease, reproductive disorders, liver disease. You know, obese people tend to have fatty liver and NAFLD and all. Ultimately, even obese people have more chances of cancer compared to non-obese people. So also diabetes contributes to a great extent for the cardiovascular diseases. And what are the other things that contribute to it? Age, genetic predisposition. If there is a strong family history of the heart disease, then also you'll get it. Ethnicity, Asians have more cardiac disease, high blood pressure, obesity, physical inactivity, smoking. So meaning that diabetes only contributes to 16% of cardiovascular disease. Another 84% is due to all other 7 factors, and only the 1/6 of it is due to diabetes. That you should remember. Whereas microvascular complication is very pathognomonic of diabetes as such. So how to prevent macrovascular complication? Of course, tight control of blood sugar is good. Lifestyle modification like exercising, reducing obesity, stop smoking are important. Then we have 2 important pharmacotherapies, that is treat dyslipidemia well and treat hypertension to the target. If you do that, good diabetes control, lifestyle modification, stop smoking, do exercise, reduce weight, and control diabetes and hypertension, 90% of heart diseases, macrovascular complication can be stopped. This is what is known as glucose paradox, the tardiness of therapeutic intervention. Though we know that HbA1c should be to the target of 6.5 or 7, but still there is a therapeutic inertia, both from the point of view of the physician as well as the patient also do not agree to take the treatment properly. Adverse cardiovascular effects of the anti-diabetic drugs is also known, because some of the drugs like rosiglitazone and all had an adverse cardiovascular effect, caused congestive heart failure. Contribution to macrovascular disease are related to glycemia, as I said, obesity, cholesterol, and inflammation. Today we know one of the important causes for macrovascular disease is the inflammation as such. So the non-pharmacological therapy are sensible sustenance, structural physical activity, stress management, sleep hygiene, and substance abuse cessation. People who do the night duty, BPOs, and they work in the night, they sleep in the morning, they have more stress and they are more likely to get diabetes rather than people who are working in the morning. We are trying to reverse the human cycle as such and day and night cycle. That is why with these things, sleep hygiene, very important. A healthy person should get at least 6 to 8 hours of sleep as such. Now, what are the pharmacological approach to prevent the macrovascular? As I said, overcome obesity, do exercise, good diabetes control, good blood pressure control, cholesterol control, and endothelial and platelet health. As we know, there are clopidogrel and aspirin, many drugs which will preserve the endothelial cell as such. We have many choice of therapy, whether insulin or sulfonylurea or the other ones which can reduce the complication as such. With insulin and sulfonylureas are less promising, whereas the SGLT2 inhibitors and GLP-1 analogs are more promising. Thiazolidines hold good promise as insulin sensitivities may offer cardiovascular benefit, but not rosiglitazone. Then statins, fibrates, and agents that disrupt angiotensin II signaling can also reduce macrovascular complications. As you know, aspirin used judiciously in those with high cardiovascular risk can reduce the macrovascular disease. Most important, treat hypertension and cholesterol. I am repeating this so that it's very important, not just diabetes. The microvascular complication, as you know, are because of chronic hyperglycemia, and they are retinopathy, nephropathy, neuropathy, and time to develop this is much faster compared to macrovascular. Even 3 to 5% of patients at beginning can have retinopathy, neuropathy, nephropathy because these things can start even in pre-diabetes. This is a landmark trial where we were all part of it and we have published it. And it is a 2 years follow-up of patients. It's a real world one. At 1 year, microvascular complication was significantly higher in individuals from Indian non-metropolitan cities than metropolitan cities. Neuropathy was the most common microvascular complication in both the groups compared to other retinopathy and nephropathy as such. Because retinopathy and nephropathy can take 15 to 20 years, whereas neuropathy can occur even less than 5 years because of metabolic pathway and uncontrolled diabetes as well. What are the predictors of microvascular complication? Increasing age. Longer the age, duration of diabetes, and more aged person is neuropathy. Even non-diabetic elderly person also develop neuropathy. Comorbid hypertension, non-adherence to diet. These are some of the causes. So this is how diabetic microvasculature as such, highly susceptible to damage due to chronic hyperglycemia and genetic predisposition. Complication of essential organs like kidney, eyes, and the nervous system. So that's why we should prevent. This is the overview of it. You see the high amount hemodynamic changes like blood pressure, salt fluid balance, metabolic, that is glycemic control and lipids, then genetic susceptibility and gene expression. All the three, hemodynamic, metabolic, genetic factors, they make cellular changes, then gene modulation and energetics, protein expression, immune system recruitment, and then ultimately cellular dysfunction and death. This is how the apoptosis occurs. Same thing is responsible for retinopathy, nephropathy, and neuropathy complication due to the endothelial dysfunction as such. Then there is an interaction among glucose homeostasis. We have already discussed enough about the octet as such. So that is how you see the final complication prone cells are affected by IGF, which comes from the liver, or glucose, which comes from the gut and kidneys, as well as the decrease in the insulin from the pancreas as such, and the adiponectin, which comes from the fat cells or free fatty acid. So all these things contribute to complication, whether it is podocytes in the kidney as such, or even the retinal cells as such. How do we detect the earliest microvascular complication? Nephropathy, urinary microalbumin. You know, the normal albuminuria is less than 30, and between 30 to 300 is microalbuminuria. More than that is macroalbuminuria. By detecting microalbuminuria, which is still reversible, you can detect early nephropathy, control diabetes, hypertension, it will come down. Neuropathy, monofilament testing, all of you must have seen monofilament, and then that is the one earliest you can see neuropathy. Retinopathy is by dilated eye examination, fundus photography, intravenous fluorescent angiogram, which is hardly done these days, optical coherence. Now there are simple tools and which you can do in your clinic. I'll show you later on how to check microalbuminuria and the sensation as well as the fundus camera as such. So as we have already discussed, diabetes management is medical nutrition therapy, non-pharmacological, exercise, smoking cessation. This is very important from the point of view of the cardiovascular disease or macrovascular disease complication prevention. Intensive therapy is very useful. So also antihypertensive medication, whether ACE inhibitors, beta blockers used properly, can control diabetes blood pressure very well and prevent macrovascular complication. As you know that prevention contains 3 steps: primary prevention, secondary prevention, tertiary prevention. Primary prevention is early screening and preventing complications. Secondary one, where medication in elderly with long-term diabetes and comorbidities. Tertiary, when early detection management of microvascular complication, when complications have already happened, then that is rehabilitation. Coming to microvascular, that as I said, EGFR is very important. Normally EGFR is above 90. But there is age-related also, between 50 to 60, 60 to 70, 70 to 80. You should know what is the EGFR. It's not that everybody, even at 80 years, will not have it. Even 60 to 70 may be normal at that age. Albuminuria is the earliest one. Then apart from that, you should look at chronic health concerns and comorbidities and diabetes control and acute health ones like urinary tract infection and other parameters like hypoglycemia, lipids, blood pressure are equally important. Urinary albumin and estimated GFR, annual assessment in patient with type 2, irrespective of treatment. Every year, please get blood urea, creatinine, urinary albumin, and measure the eGFR, and then see whether it is coming down or not. In patient with diabetes, if urinary albumin, as I said, more than 300 milligrams per gram of creatinine and our estimated GFR rate, 30 to 60 ml per minute per square meter, should be monitored twice a year. Otherwise, once a year is good enough, but if it is already affected, microalbuminuria check once in 6 months as such. Diagnosis. Based on the presence of albuminuria and a reduced eGFR, absence of signs and symptoms of other primary cause of kidney disease. There are very simple formulas you use using creatinine and the height and weight of the patient to calculate the eGFR, which may not be perfect, but still these are the ones which are useful. Active urinary sediment, rapidly increasing albuminuria, nephrotic syndrome, rapid decrease in eGFR, absence of retinopathy, suggest alternative additional cause of kidney disease. Usually, the retinopathy and nephropathy go hand in hand. If there is a disparity between nephropathy and retinopathy, there are no eye changes, but significant renal, you should check with a nephrologist. He may do biopsy also to find out that this kidney disease may not be due to diabetes, other cause. Where many times 4 to 5 years diabetic having nephropathy, then they found out it's maybe glomerulonephropathy and other immune-mediated nephropathy, and we may be able to treat it. So if you have in doubt, please refer to nephrologist for a proper diagnosis, and even if necessary, they will do the kidney biopsy, which is the ultimate know the pathology of that. Now, this is what I was telling, that unlike in the past, you don't have to send the patient to a far off place, because many times patient may not do the test. This is almost hand size, palm size meter with 2 batteries, and it's highly reliable. And this one with the use of spot urine, you don't need to collect 24 hours. Results are highly reliable without influence of urine dilution concentration. Albumin creatinine ratio is effective. This is what you are going to say. Just insert this strip, put the urine, and it can measure not only that, it can measure glucose, protein, bilirubin, urobilinogen, and also pH, ketone bodies, nitrates, leukocytes, and urinary creatinine and all that you can measure. You see, almost you can see the 12 parameters are there with one strip. So you can do a point of care, and then all these things can be checked in your own clinic, handheld machine. You don't need any big lab at all. Then this is how you see. Usually the CKD means chronic kidney disease. It depends upon two things. One is albuminuria, as you see. Next is EGFR. Then it is graded. Albuminuria, G1, normal or high. G2, G3, G4, G5, P6, when it is renal failure. When the EGFR is 90 and more, it is normal. 60 to 89 is mild. 45 to 60 is mild. Then moderate is 30 to 44. Severely decreased EGFR, 15 to 28. And below 15 is severe kidney failure or end-stage renal failure. So also albuminuria is graded as A1, A2, A3. A1 is normal to mildly increased, less than 30 milligrams per gram. And if it is moderately increased, 30 to 300, as I told you, more than 300 is severely increased macroalbuminuria. So if you have grade 1 of in EGFR and grade 1 of this, then normal, you don't have to worry. Whereas if it is more than grade 3 here, that is EGFR below 60, and then you see that albuminuria is also present, then you have to treat this patient. If it is very high, you have to refer, as you can see here, grade 4 or 5 with 2 to 3 grade of albuminuria. You have to refer that patient to nephrologist who is better equipped to investigate and treat. This is simple chart. Now, when to refer a patient. So prevention of progress of renal disease in people with diabetes is primary prevention, good diabetes BP control. Put every patient of diabetics on ACE inhibitor unless they have contraindication. Then they develop microalbuminuria. Then it is secondary prevention, that is good BP control. And you see ARBs as such, ACE inhibitor. If nephropathy develops tertiary prevention, then ultimately it will be end-stage renal disease or death. So I have to refer the patient at this stage when they have microalbuminuria to nephrologist for further investigation, proper treatment. So how to treat diabetic nephropathy? Most important, cardiovascular risk reduction, because nephropathy and cardiac disease is a double trouble. Good blood pressure control, diabetes control, inhibition of renal angiotensin, the system by either ACE inhibitors or ARBs as such. So what are the recommendations? Try to achieve HbA1c below 7%, and please use SGLT2 inhibitors. Even up to 30 eGFR, SGLT2 inhibitors can be given because it reduces the urinary albumin excretion. It also protects the kidney and also slows down the decrease in eGFR. Please keep blood pressure less than 140/90. If possible, 130/80 is better than 140/90 in a patient with renal disease or such. And RAS blocking medication also, as I said, can be used. When to refer to nephrologist? If there is a high risk in the patient, any abnormality in history, examination, preliminary investigator, which shows this may not be diabetic kidney, other causes, because some of these immunoglobulopathies respond very well to steroids. The next one is neuropathy. Diabetic neuropathy occurs. One, metabolic neuropathy, when the blood sugar is 400, 500. When you control diabetes, immediately within days or weeks will come down. Next is duration. By the end of 10 years, 80% will have neuropathy. By 20 years, 95% will have neuropathy. It is diagnosis of exclusion. Up to 50% may be symptomatic. Another 50% may not. Tingling, numbness, bilateral symmetrical polyneuropathy. Recognition and treatment of autonomic neuropathy may improve symptoms and reduce sequelae and improve the quality of life. Then assessment. All patients should be assessed for diabetic peripheral neuropathy, starting at diagnosis initially, and every year you must check touch, heat, vibration, which you can do. Take careful history of diabetes, symmetrical polyneuropathy, assess temperature, pinprick, vibration sense using a tuning fork. All of you have been doing it day to day. So even with a pinprick or temperature one, vibration sense, monofilament, this is the most important. Annual 10-gram monofilament testing to identify at risk, ulceration and amputation. This is what I showed you already, how we can do the nephropathy, albuminuria in your clinic within minutes. Like that, this is called as NeuroTouch. This is an apparatus where you can see like this, whether it is touch, whether it is vibration, whether it heat or cold. All these sensations can be just measured with this equipment, and you can see monofilament here attached to it. It has got monofilament, it has got temperature, it has got vibration, it has got touch sensation. So all of them can be done, and this is how you can get it. Is cloud-based. and it can be transmitted to a EMR or one to patient's mobile phone also. So how to diagnose? The various things. One is diabetic autonomic neuropathy, beat to beat variation, then RR interval, variable RR interval, then cardiac autonomic neuropathy, gastroneuropathy, patient has bloating and he has got the other things, regurgitation and all, genitourinary disturbances, difficulty in passing urine retention. So all these things also contribute to diabetic autonomic neuropathy, cardiac autonomic neuropathy, gastroparesis, and genitourinary disturbances. So how to control it? Good diabetes control, assess and treat, reduce the patient's pain with neuropathy. And these are all the drugs, whether in isolation or combination, pregabalin, dolutegravir, and gabapentin are recommended. And there are many other drugs also. Every 1 or 2 years, you are getting new treatment for diabetic neuropathy. This is how you see diabetes patient with neurologic pain. Then you can see good diabetes control, still not controlled. Then you can see mood elevators like nortriptyline, amitriptyline, carbamazepine. These are all the drugs which have been used for the last 3 to 4 decades. They don't respond either. You can use gabapentin or pregabalin. Pregabalin is given in a dose of 75 to 150 milligrams. Though it can go up to 300, most of our patients do not tolerate 300, so 75 to 150. Whereas gabapentin should be used in 100 to 300 milligram divided doses. I said, duloxetine is the other one, and also venlafaxine or the other one. So you can use 1 or 2 or 3 combination. Of course, if the pain is more, then you can use pregabalin or tramadol. Tramadol is one drug which is very good painkiller. And in all these things, that capsaicin, lignocaine, nowadays you have so many ointments which are available. In mild cases, all of them contain either counter-irritant like capsaicin, which is an extract of the what you call capsaicin, which you get from your regularly mirchi or whatever, red chili, what you use. Lignocaine is a local anesthesia. These are all preparations which are there. You can use permutation combination of this. Ultimately, you treat them, assure them it will go 3 months, 6 months, gradually pain or burning. Sometimes it is so severe, patient may commit suicide. That is why the nortriptyline, amitriptyline, and these are all the mood elevators are very useful along with pregabalin and even painkillers as such. So next thing is foot ulcers and amputations are a result of neuropathy. When there is no sensation, even if it is small, wound becomes big, and then it may have a peripheral vascular disease. Then early recognition treatment can delay or prevent adverse outcome. I used to see 40 years back that every year 3 to 4 amputations. Thanks to prevention, the last 12 to 15 years, I have never seen a single amputation except small toe or digits amputation in them. It's a major cause of mortality, morbidity in people with diabetes. If amputation is done, then chance of losing other limb is almost 40% in the next 2 to 3 years. If somebody has amputation, same vascular disease are occurring in the heart and brain, his chances of survival of 5 to 10 years is still less. That's why you have to prevent peripheral vascular disease and amputation. ADA recommends comprehensive foot evaluation every year. Patient with sensory loss or pre-ulcer or amputation should have their feet inspected every visit. Sometimes, okay, doctor, they say, no, please take out your shoes, please take out your socks, lie down, please examine properly the foot. Look for any callus, look for any fungal infection between the digits, I said, because many times they don't know. Only when you examine, otherwise they will not have sensation. Carefully look at the nails, ask them how to cut the nails. So these small precautions, last 20 years I have seen amputation becoming less. You can also do this ankle brachial index. Those who have got a less than 0.7, refer to vascular surgeon. There are procedures where they can do the bypass surgery and then they can prevent these things. Very important. Prior history of ulceration, amputation, Charcot foot, deformed foot, angioplasty, vascular surgery, cigarette smoking, retinopathy, renal disease. So when any of them are there, then you see that they have a risk of peripheral artery disease. Examine and inspect the skin carefully. If the hairs are lost, if the skin is black, that is an indication that there is a decreased blood supply. Assess foot deformities. Then you see valgus and others, Charcot joints. Assess the neurological assessment by touch and vibration. So ADA recommends multidisciplinary approach, refer to foot care specialists for ongoing preventive care and lifelong surveillance, general preventive foot self-care education. There are a lot of things. Ask them daily, examine the foot. When you get up in the morning, you see the hands. Like that, look at the feet. If you cannot ask your younger children, grandchildren to look at it, don't cut the nails with a blade or scissors. Please cut it with a nail cutter or go to podiatrist. You'll cut it properly so in no ingrowing tiles. Examine the feet regularly. Either the patient examines or you can examine for any callus, ulcers, or between the toe. Then you will see the fungal infections. Candidiasis is very common. It starts like that, then it increases. They may lose their foot also or amputation. Use specialized therapeutic footwear for high risk patients. Nowadays, diabetic footwear are available. Don't take pointed shoes. If your size is 7, take one size extra. Very important. Don't have tight fitting shoes. Whatever your size of the shoe, take one size extra. Always wear socks. Preferably wear the white socks, because if they wear black, even if it is dirty, they will not. If you wear white socks every day, whenever you wear it, please change that socks so that the foot is healthy and there is no infection. Coming to retinopathy, highly specific vascular complication of both type 1 and type 2, prevalence strongly related to both duration of diabetes and glycemia. Poor control of diabetes, longer duration of diabetes leads to retinopathy. Most common causes of new case of blindness among adults 20 to 74. Fortunately, these days, the diabetic retinopathy causing blindness is very less. I have hardly seen anything 30 years. If a patient comes to you every 3 to 6 months regularly, if you annually check up, control diabetes, blood pressure, cholesterol, nobody will lose their vision because of that. Except for maculopathy, which is not directly related, glaucoma, which may become more common, and cataracts are treatable. So every year, send them to ophthalmologist. Otherwise, you can measure the blood pressure if you have then the non-invasive method, applanation tonometer and all that. Then this is how individuals with type 2 should have initial dilated comprehensive checkup. Refer to ophthalmologist. Even in a small place, there is ophthalmologist. If no evidence of retinopathy for one or more annual exam, screening is recommended 1 to 2 years, not 6 months. Then women with pre-existing diabetes should counsel on the risk of development during pregnancy. Eye examination should occur before pregnancy or in the first trimester, because during pregnancy, the retinopathy may worsen as such. This is what I was telling you. First is I told you how to examine urinary albumin creatinine ratio with the strip. Next, I told you how to use neurotouch and such things where you can measure all this. Then you can have this fundus camera. It's a handheld one, hardly about 1 kg or even less than that. New design with 30% lesser weight, fully handled. This is the handle where you can have it, and optional chin rest also. One click montage. You can just attach to it like you see here the mobile phone, and you can take a figure. External fixation target for peripheral limit. Once you get this, this is normal fundus, subnormal. Now these cameras are come with artificial intelligence. It says here there is some retinopathy here, there is some retinopathy here. It shows normal, abnormal. If it is abnormal, then refer to ophthalmologist. How to manage this? Stepped approach should be adopted to manage hyperglycemia. GLP-1 analogs must be used with caution. Good control of blood glucose, blood pressure, and lipids. Ask patient to stop smoking. These are all the 4 things. Poorly controlled diabetes, lipids, blood pressure, smoking can worsen retinopathy. Discourage use of alternate medicine. Many times they take alternate medicine thinking that they are going to get a cure. Then they get up a problem. To summarize my talk, long-term complications can be present and diagnosed in people with type 2 diabetes. We have published a paper known as CINDI, Complication in Newly Detected Diabetes. So for type 2 diabetic, even at the onset of diabetes, please check for all the complications like retinopathy, nephropathy, peripheral neuritis. Then also get their lipid profile, get their creatinine, urinary albumin, and repeat these things annually. Complication can lead to permanent neurological consequences or death, because autonomic neuropathy, cardiac neuropathy can lead to cardiac problem, even death also. Early detection is essential to prevent disability and death. Self-management is an important point of successive preventive and delaying diabetes complication. You should tell patient at the beginning, educate him about diet, exercise, lifestyle modification, prevent obesity, do exercise regularly, 150 minutes of exercise per week, and also tell them that you have to do self-monitoring and you should also get HbA1c every 3 months if possible, or minimum once in 6 months. Have an eye checkup, foot checkup, vascular assessment, as I told you, ankle brachial index, which is also a simple equipment a nurse or SLC technician can do. It can go a long way in detecting early microvascular, macrovascular complication. If you have facility, do an ECG every year. If you have a doubt, refer to the cardiologist. You also have the urinary microalbumin examination in your clinic. All of you can have fundus camera, which will be useful to screen every patient. And if it shows any abnormality, maybe 5% of the patient, then you can refer to ophthalmologist. Don't forget to look into the eye for cataract, as well as retinal examination, and also applanation torometer, where within seconds you can see intraocular pressure. Anything more than 20 millimeters of intraocular pressure, left or right eye, should be referred to a glaucoma specialist. Diabetes, hypertension, or combination of both cause 80% of end-stage renal failure. That's why treat both diabetes, hypertension. Both diabetes, chronic disease are strongly associated with cardiovascular disease. If a patient has got diabetes, chronic kidney disease, then the mortality is higher. Controlling diabetes can reduce all these microvascular complications. Most effective strategies to reduce impact of kidney disease in diabetes are to prevent diabetes itself and to diagnose and treat kidney disease early and effectively so that patient can have a good quality of life. Very important is early diagnosis, timely treatment of diabetic retinopathy. Every year, checkup of retinopathy or going to ophthalmologist can prevent blindness as such. That is very important. Please refer the patient to ophthalmologist if you do not have facilities. Then optimize blood sugar, blood pressure. Keep HbA1c below 7, if possible 6.5. Keep blood pressure below 140/90 millimeter, if possible even 130/80. And by regular screening of diabetic retinopathy. Thank you for your attention. I have taken nearly 35 minutes. And if there are any questions, please put it in the chat box and we can answer those questions. There I can see a few questions here put by Dev Tyagi. One of the doctors have asked, toes are turning black and one of the toenails has already come up. Is this happening because he is diabetes? No. As I told you, if there is a blackening of the skin, what does it mean? Decreased blood supply. If the toenail has already come up, that means there is decreased blood supply to the toenail. Please immediately refer him to a vascular surgeon. What will vascular surgeon do? He will do the Doppler, because all of us may not have Doppler. If you have facility, you can do ABA, ankle brachial index. Very simple. Measuring the blood pressure in the brachial artery in the arm, and then measuring the blood pressure in the ankle as such. So this is known as ankle brachial index. So if this index is 1 or more, that means blood supply is good. If that is less than 1, 0.9, 0.8, less than 0.7, it should be referred to vascular surgery. Many times ankle brachial index may be normal because that is larger vessel. Smaller vessel may be affected in this case. First sign of this is one, that the skin, you see the turgosity is lost. Skin becomes black because decreased blood supply. Hairs are lost. Then you will see nail will fall off. So this patient, what the doctor has asked, toes turning black, one of the toenails has already come up. It may be a peripheral vascular disease. Please refer him to vascular surgeon. He will do Doppler. In case if there is obstruction, he will do an angiogram and he can do angioplasty or bypass to save the foot or prevent amputation in such patient. Other question is, one of my patients get panic attack symptoms when blood sugar falls below 90. Why? So usually the hypoglycemia, neuroglycopenia occurs when it is below 70. At 90, it will not. We don't know what is measured 90 by glucose meter. Maybe more than that, less than. By and large, as long as, because normal fasting blood sugar is 70 to 90. So even if it is 70, 75, one should not get panic attack, hypoglycemic attack, neuroglycopenic symptom. But many times when the patient reads this reading, he thinks 100 is normal, anything above 100 is good. When they see 80, 85, doctor, I have got low sugar, I feel dizzy, I feel I am falling. So when they see that reading in their mind, they think 90 is very low, 80 is very low, I should take glucose. So that is why if the patient has panic symptoms, you can give alprazolam 0.25 milligrams. And whenever such panic attack occurs, even if the blood sugar is 90, even though it is not low as such, don't ask him to take glucose, it will go to 300. Ask him to have some biscuits or a fruit or some half glass of milk. Then take half alprazolam, close your eye, and then rest for 15 minutes. Most of the panic attacks go away. Otherwise, it may be panic attack associated diabetes, not necessarily due to hypoglycemia. If you still think patient cannot manage, you are not convinced hypoglycemia, you can refer the patient to a counselor or psychiatrist who will treat panic attack properly. There is a third question, how to make sure to get rid of ketones in the system after illness. Very good question. When do you measure ketones? Usually, when the blood sugar is more than 250, 300, you must measure urine ketone bodies. When you check urine ketone bodies, if it is just traces or 1+, it is not important. If the urine ketone bodies are 2+, 3+, 4+, then it's important. And again, ketosis is different from ketoacidosis. Ketosis may not be dangerous. Ketoacidosis may be dangerous. When the ketone bodies are high, when you measure in the blood, you measure beta hydroxybutyrate, BOB. So beta hydroxybutyrate is the one ketone bodies that is measured in the blood. So urine ketones may not be very quantitative. You just measure 1+, 2+, 3+. Traces are 1+ is not changed. Next question is, why does it occur? It occurs because if the patient is not taking enough of carbohydrate, ketone bodies can occur. Nowadays, you see, doctor, I want to get my diabetes reversed. I want to get my diabetes cured. I went to a state where they gave me keto diet. What do they do? Keto diet is 20, 30 grams of carbohydrate per day, 60, 70 grams of proteins. When they have a high carbohydrate, less carbohydrate, high protein, high fat. So that is known as ketotic diet, where they give almost 50, 60% of the calories coming from fat, 20, 30% coming from protein, hardly 10% less from carbohydrate. So when you use a ketogenic diet, when you take less carbohydrate, when you take more fat, the end product of fat metabolism is ketone bodies. That is why you may get ketone bodies. I have seen one of my friends, she thought she wants to lose weight, did a drastic keto diet. After 2 months, she was very sick and her bicarbonate level was high. She was taking high protein, high fat diet, no carbohydrate. Ultimately, she has to put a drip for 2 days. Then she was all right. That's why don't do such crash diets or what they call keto diet and all, unless it is supervised by the doctor. If you don't know, tell them, sorry, I don't know much about this keto diet. My belief is, if you just follow low carbohydrate diet, so that is known as low carbohydrate diet or low calorie diet, you don't have to go to 20 grams. Take 30%, 40% carbohydrate, maybe 30% of protein, then 30% of fat. Then it's okay. If you take 80% of fat, 10% of carbohydrate, 10% of protein, then you get into this problem. So other important thing is what is known as euglycemic ketonia. This occurs with SGLT2 inhibitors. Though blood sugar is less than 250, 200, still ketones occurs. And that is because of the SGLT2 inhibitors. Now we have got many of these dapagliflozin, empagliflozin, all that. So be careful that patients on this, if they are already taking very high dose of insulin and taking SGLT2, can cause ketone bodies. And you know, there are various mechanisms how SGLT2 inhibitors will cause ketosis, because they take the super fuel. What is super fuel? Is ketone. Ketone bodies are the super fuel, and that is used by the cardiac muscle. That's why these ketones will increase when you use SGLT2 inhibitors. So even though blood sugar is less than 250, 200, that is called as euglycemic ketosis. Acidosis is different. When you say diabetic ketoacidosis, it is not only the urine ketones are high, the blood ketones, beta hydroxybutyrates are high, but the pH of the blood comes down below 7. Then it is dangerous. Ketosis alone is not so dangerous. Even in pregnancy, because more fat is mobilized, you may get ketone bodies. But if ketosis is associated with acidosis, then you have acidotic breathing, and you will see that pH is below 7. Then patient has to be admitted in the hospital and has to be given saline. Dehydration, infection should be treated first, and small dose of insulin as such. So I think I have answered all the questions. I don't see any more questions apart from this. Yes, there is a question here. Choice of therapy for diabetic kidney disease patients and high risk of developing CVD. Very good question. Choice of therapy diabetic kidney disease is, now the first treatment is that don't use drugs which are harmful. Suppose pioglitazone, if your patient is pioglitazone, withdraw that. Don't introduce metformin when the diabetic kidney disease is already there. And if the dose is there, don't increase metformin. Not that you should stop, don't increase metformin when diabetic kidney disease is there, and don't introduce first time the metformin is there. Next thing is SGLT2 inhibitors. SGLT2 inhibitors can be used from 90 even up to when the EGFR is up to 30, because as of now, we don't use below 30 diabetic SGLT2 inhibitors. Maybe next year we'll have data, we may give 25 or even 20 also. So as of now, you can use SGLT2 inhibitors as long as the EGFR is up to 30. Then when there is a kidney disease, please refer them to a nephrologist, because there are many things he has to investigate. It may be due to diabetic or not, they may do kidney biopsy. They will also adjust the drug. You have to use certain drugs. Sometimes you have to look at potassium. If the potassium is high, you have to reduce ACE inhibitors or ERB, because that could be the cause. Sometimes when you introduce the ACE inhibitor ERB, if the creatinine increases, you have to stop it. So that is why diabetic kidney disease, please refer. You take care of diabetes, but let the nephrologist. Again, high risk of developing the cardiovascular disease also. Any patient developing high risk of cardiovascular disease, again, SGLT2 inhibitors and GLP-1 analogs. Results have shown SGLT2 inhibitors are important in diabetic kidney disease as well as heart disease, because it reduces the all-cause mortality, cardiovascular mortality, reduces the heart failure due to the cardiovascular involvement. Again, there are 3 types of heart failure. Heart failure with preserved renal function, where it is 50 or more, and heart failure with a moderately reduced one, where it is between 40 to 50 and less than 30 is known as this. So you can categorize into heart failure with preserved renal function, heart failure with moderately reduced renal failure, and again, heart failure with moderately reduced or severely reduced. In all these 3 patients, you can definitely use this. That is the importance of the SGLT2 inhibitors in cardiovascular disease as well as renal disease. The best drug is, of course, when both are there, SGLT2 inhibitors are the first and GLP-1 analogs are the second. GLP-1 analogs are also important because they also give cardiovascular protection as such. But when it is renal, SGLT2 inhibitors are the first. Are there any questions, Dev?
No, sir. So
Okay.
thank you so much, sir, for such an informative session and taking us through the diabetes complication parts and addressing all the queries very nicely. Thank you so much, sir. And thank you everybody for joining us today. So we shall meet up in the next module of NDEC course. Thank you, sir. Have a great evening.
Thank you. Take care. All of you have a great weekend. Bye.
Bye.